The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Jackie Leiser. I'm a manager with the CAQH Core team, and I'd like to welcome you all to today's CAQH Core Industry Webinar, where we're going to discuss preparing for NCVHS review of the proposed operating rules for federal mandate. I'll kick things off with running through our agenda quickly. We'll start with a brief overview of CAQH Core, followed by a federal update where we'll discuss how operating rules become federally adopted and where we are in the process for our proposed operating rule set. Next, we'll provide an overview of each of the new and updated rules in that proposed rule set, including updates to CAQH Core connectivity, infrastructure, and eligibility and benefits operating rules, as well as our brand new CAQH Core attachments operating rules. We'll then share some of the resources from the CAQH Core team that we put together to assist with NCVHS comment letters, along with a summary of the NCVHS rule package. Lastly, we'll wrap things up with a discussion with CAQH Core board member and immediate past chair, Tim Kaya, who I'll formally introduce in just a minute. But before I introduce him and pass things over to our core team, I just want to run through a few quick logistics for today's presentation. If you'd like, you can download the slides right now. You can access them in the handout section of your GoToWebinar menu on the right-hand side of your screen. The slides, along with a recording of today's session, will also be available on our events page after the webinar, and we'll also send out an email to any attendee and registrant in the next 1 to 2 business days. If you have any questions throughout the presentation, you can submit them at any time, and you can do that using the questions panel on your GoToWebinar menu. And with that, I'll introduce Tim on our next slide. We're excited to have Tim Kaya joining us today later in the presentation. He is the president of Network Support, and EHR Strategy and Operations for Optum Health, where he's responsible for the development and execution of Optum Health's national network contracting operations. This includes payer and provider contracting to help support risk management growth across all lines of business and products. He's also responsible for developing and executing the next generation of Optum Health's EHR and digital adoption strategy across Optum's clinics and operations. As I mentioned briefly earlier, Tim is the immediate past chair for the CAQH Core Board, and he's a member of the CAQH Core Board today. We're excited to have him joining us for our discussion later on in the presentation. And with that, I'll pass things over to Erin Weber, who's going to get us started on our CAQH Core overview.
Thanks, Jackie, and thanks everyone for joining us today. I know it's a really busy time of year, so we appreciate you taking an hour out of your day. For those of you that are newer to CAQH Core, I'm going to give a quick overview of the work that we do and then dive into some updates around our work with the proposed operating rules to NCVHS. CAQH Core is a nonprofit initiative founded by health plans, providers, vendors, government entities, associations, and other organizations more than 10 years ago now to develop operating rules or business rules to support the administrative transactions in healthcare. When HIPAA was first passed, there was not a lot of consistency or uniformity in how the standards were being used. So the industry came together to develop operating rules modeled off the financial services industry to create some common frameworks and roads of the rules to support automation within the industry. We see our role not only as a convener of our more than 100 participating organizations to develop, vet, debate, and ultimately approve operating rule requirements, but we also drive industry adoption through our certification program. We measure the impact of the rules through pilots and ROI initiatives. And we also provide a lot of industry education sessions, such as the one we are having today. We are governed by a multi-stakeholder board of directors, which is equal parts provider representation and health plan representations. We are also advised on the board by leadership from all of the SDOs and WEDI. On the next slide, just a quick highlight. Many of your organizations, I'm sure, are participating in our efforts here at CAQH Core. And on the next slide, I'll highlight how these participating organizations come together to develop operating rules. It is truly an industry, collaborative, consensus-driven effort. We start with opportunity identification. Our Internal team and our board will identify priority topics, conduct environmental scans, industry interviews, and will form advisory groups to help pinpoint particular opportunities for operating rule development. Then we'll convene our subgroups. Anyone from a core participating organization is welcome to join our subgroups to develop, debate, and straw poll potential operating rule requirements. The next stage is really when our formal rule approval process begins through our review workgroup activities. That group requires a quorum and majority support of a draft operating rule to move forward. Then we have our full core vote. And this is any core participating organization that creates, transmits, or uses the transactions has a vote at this stage. That's because it's those organizations that have to invest the resources to implement the rules. We want them to have kind of the final say on those operating rules. At this stage, we need at least 60% of our participating organizations to engage in the ballot and 2/3 approval to move the proposed rules towards the final stage in our process, which is our board review and vote. To date, CORE has developed 8 sets of operating rules, 3 of which are federally mandated, and we've outlined those rules on this slide. This is important. I want to highlight those pink rules because those are the federally mandated rules, some of which the CORE board has proposed to NCVHS to be updated. Many of these mandated rules were developed about a decade ago, and so it's been time to update and refine the requirements to align with current and emerging business practices. And that's a great segue into the federal update section and an overview of the process that is used for CAQH CORE to propose operating rules for federal mandate. Now, back when the Affordable Care Act was passed, the concept of operating rules was included in the Affordable Care Act and added into HIPAA. HIPAA requires that all of the administrative HIPAA transactions have adopted operating rules as well. CAQH CORE was designated as the National Operating Rule Authoring Entity by HHS in 2012, and we have continued to develop operating rules for those HIPAA standards since then, as well as other non-HIPAA mandated standards. There is a whole process for the CORE board to propose operating rules for federal adoption. And I will walk through this process we used this time around. The CORE board reviews the full set of CORE operating rules and determines whether any of the new or updated operating rules are ready for potential federal adoption. Once they vote on a set of rules, and this set of rules that we're working through this time was unanimously approved by the CORE board, the CORE board then drafts a formal letter and sends it to the National Committee on Vital and Health Statistics, which is a federal advisory committee to HHS on topics related to administrative simplification, HIPAA, privacy and security, population health, among other topics. Once NCVHS receives a recommendation from the CORE board, which happened in May of this year, that then triggers a process whereby NCVHS plans a public hearing to solicit industry feedback on the operating rule proposal. So NCVHS has scheduled a public hearing for January 18th and 19th of next month. I can't believe January is next month. And they have also published a request for comment where they're asking all industry stakeholders, including those who may not have been invited to participate in the hearing, to provide comment on the operating rule proposal. And those comment letters are due on December 15th, which is 1 week from today. I also want to note that X12 has also submitted recommendations for updated versions of their standards, beginning with the 835 and 837 transactions. And those are also being reviewed by NCVHS in this request for comment and at the hearing in January, although it is a separate request from the operating rule proposal. Once NCVHS hears all of the industry feedback on the operating rule proposal, they will then send a letter to the Secretary of HHS, including a recommendation on whether those operating rules should be federally mandated. If a mandate is the approach, HHS then goes through its own interim final rulemaking process. Typically, once HHS mandates an operating rule, industry has 25 months to implement and adopt the new rules. And of course, there's a comment period associated with that process as well. So industry has multiple opportunities to provide feedback during this federal adoption process. So that's the process we're working through right now. On the next slide, I'm just going to give a quick overview of the operating rules that have been proposed to NCVHS by the core board. Several updates to currently federally mandated operating rules have been proposed, including updates to the infrastructure rules for the eligibility, claim status, and electronic remittance transaction. The core connectivity rule, right now the phase 1 and 2 core connectivity rule is federally mandated. The board has proposed version C4 to replace those, as well as an operating rule for eligibility and benefits data content updates and patient attribution. Additionally, the core participants recently developed new attachment operating rules for healthcare claims and prior authorization, and those rule sets include both data content and infrastructure rules. We'll touch on it in a minute, but I know top of mind is the fact that there is not yet a named HIPAA standard for attachments. What the board is recommending is that NCVHS recommend to HHS that when an attachment standard is adopted, that operating rules are adopted at the same time by HHS to ease industry implementation. And we'll talk about that a little bit later in this presentation. Finally, I want to highlight that these rules were developed over the course of the last 2 years with significant industry engagement and participation. Many of you, I'm sure, were engaged in the process. We probably held more than 50 industry calls to develop these rules, went through countless straw polls and balloting processes, and each of these rules received at least 88% support from the core participating organizations, which are really representative of stakeholders across our healthcare system. I'm now going to turn things over to my colleague, Bob Bowman, to walk through some of the rule requirements included in these proposed rules. Bob?
Great, thanks, Erin. And as Erin mentioned, we do want to walk through each of the 4 sets of rules that are part of this rule package. We're going to start with the update to the core connectivity rule. As Erin mentioned, the 2 previous phases of the core rules are federally mandated now. And you can see the list of their requirements on the left-hand side of the slide. Not to get into much detail, but the newer version of the core connectivity, the VC4.0.0, continues to meet the industry needs in administrative and clinical data exchange. Not only does this new version extend requirements from the previous versions, but also builds upon them and extends those requirements for actually making it a more secure interactions between providers and health plans. The core connectivity continues to support SOAP as a messaging standard and adds support for RESTful web services APIs. This helps allow for more contemporary web-based data exchanges. With the inclusion of security and authentication protocols like TLS 1.0 or higher, X509, and OAuth, data exchange is much more secure. These more contemporary methods of securing data and authenticating trading partners really allows for both sides of that equation for the data exchange to feel confident of who they're exchanging data with, that they do have a trading partner relationship with that individual entity, and that the data and the information they're receiving is exactly what they anticipate and expect. Just as Erin mentioned, the roles and responsibilities of trading partners is really key to interoperability. On the next slide, continuing with some of the requirements related to our core connectivity and some of the benefits of the adoption, not only does the updated connectivity rule align with CMS and ONC interoperability rules, It also establishes a floor on which trading partners can more easily exchange data. The safe harbor concept, the concept of trading partners, from providers to vendors, to clearinghouses, health plans, and really everyone in between, can safely and securely exchange data over the public internet via very specific protocols and through a shared network where those roles and responsibilities of each are known and identified. And establishing those roles and responsibilities are really key to ensuring that secure exchange. The connectivity rule allows entities to exchange data for any use case, be it an administrative use case like claims data exchange and eligibility inquiry, or an administrative type exchange where it's attachments to support a claim or to support a prior authorization transaction. The rule allows trading partners to more easily connect, test, and move applications and newer versions of software and new products into a production environment. So really easing that burden of implementation. On the next slide, you'll see that we have worked closely with entities over the years as they've implemented not only the previous versions, but even the newest version of core connectivity, working with them to ensure that that safe harbor requirement meets current requirements of the industry. So maybe to recap, the safe harbor establishes that floor between trading partners and allows that network to be built amongst all trading partners, all the actors in the delivery of and administration of healthcare. This network allows new connections to be established much quicker than in the past, reducing implementation timeframes from months to less than a week, and significantly reducing the cost in establishing and maintaining these connections. Hundreds of millions of transactions are exchanged for millions of users, providers, clinicians, and their support staff safely and securely. Like our update to connectivity, CORE has also updated our infrastructure rules, and that's the focus of our next section. What does CORE mean by infrastructure? On the next slide, you see that our definition here is really the infrastructure of the core operating rules are really all those nuanced questions that need to be answered between trading partners when they're setting up that trading partner relationship. These are things that are often perhaps part of your contracting when you determine the SLAs between trading partners. There may be a connectivity companion guide, or if you can imagine that first conference call between developers and project managers and sales folks, we're trying to actually make that connection between, hey, this is what our system and application does, here's how we connect, here's our endpoint, and the other folks on the other end of the health plan side. All of those same resources and staff that have to build that connection and actually do the testing and make that connection. All of those types of requirements, those roles and responsibilities, again, those things help establish are all part of infrastructure. So we see things as processing modes. Are you conducting these interactions in real time or batch? Response times. Hey, if it's going to be conducted in batch, when should you be able to go back and pick up the response transactions? Or when can you go back up and pick up that 835, right? We've processed and adjudicated the claims. When is the 835 available? So we also have connectivity based in our infrastructure, as well as acknowledgements and companion guide requirements and templates. So all of that is what we mean by infrastructure. And we've updated our infrastructure requirements, as you see on the next slide, on slide 19, from where we have, for example, 86 per calendar week for your system availability to 90% per calendar week in the new updated version. And we also have built in a requirement, for example, of 24 additional hours of downtime for those big system turns that many health plans have to go through because they're taking down various parts of their systems and applications to perhaps update them for, a good example coming up is the 1/1 effective dates for all the new membership. Some of those systems may have to come down as they put in and launch new codes and new applications to meet the 1/1 deadline that's coming up in just a few short weeks. Potentially also connectivity. We do have the new updated version. Again, VC 4.0.0 is referenced in the latest update in our infrastructure, as well as an update to our companion guide, where we've removed some of the version-specific requirements or template boiler language that we have in there to make it more of a generic. It doesn't matter what the version of the X12 transaction is. And also folks can leverage it for non-X12 transactions too, as those may be considered for implementation. As you can imagine, there are several benefits provided for this type of updates that we've made to our infrastructure rule. Right, Erin? Perhaps you have some ideas of what those might be?
Yeah, absolutely. I think the key here is when you're thinking about system availability and connectivity is that they really support the 24/7 nature of our business, right? We need to be exchanging data outside of regular business hours and supporting overall patient care. The quarterly system downtime recognizes the need for system upgrades and ensures that systems are meeting the latest standards and versioning, but also allows for that additional 364 hours a year of uptime, which means providers will have better access to data, for example, eligibility in real time, understanding coverage information, which all improves revenue cycle function. And then I think also critical, Bob, you mentioned is the move to the new version of core connectivity. Right now, organizations are required to continue support for the phase 1 and phase 2 connectivity rules, which were developed more than a decade ago. And our security and authentication standards have really advanced in that time frame. And so allowing industry to use newer approaches to connectivity and not having to maintain outdated things like username and password is a real advantage as well.
Great, thanks, Erin. And with that, we can move into our third update, and that's related to the updates that we've made, the core participating organizations made to our eligibility and benefits operating rule set. As you can imagine, the eligibility transaction is one of the most widely conducted transactions in the healthcare administrative space today, along with claims. And just like claims, it's also highly electronic, with the index report from 2021 reporting 89% of these transactions are conducted electronically. Unfortunately, that 11% gap really represents hundreds, if not thousands of hours of provider time on proprietary web portals and phone calls to a health plan. Also, health plans have to respond to all of those phone calls from providers to dig into exactly what the benefits are for particular procedures, for particular, finding out exactly what the remaining deductible is for this type of procedure or service, and what or how many visits are left on this particular benefit that might count visits. For example, physical therapy or occupational therapy, where you may have 10 visits a year, and the provider does not know how many you have left. So those types of inquiries are still burdensome. So with the update that we've made here, again, the whole idea between eligibility and benefit verification is to ensure that the data that the health plan has at its disposal is made readily available to the providers when they need it, often when the member is in the office, to determine exactly what procedures and what those dollar amounts are going to be related to those procedures are, and how to collect copay or co-insurance when understanding how you build a claim, that kind of thing. So all that's really important. Not only the process of the data, but also making sure the data is available. And so we've made 6 updates to the rule. And the first 3 you'll see on the next slide, where again, the participants identified these are the big 6 items that would really help reduce some of that administrative burden of picking up the phone and identifying these types of data needs. So the first one there you see is telemedicine. Telemedicine, as you've probably heard several times over the last couple of years with the pandemic, understanding what the benefit is for a procedure that is conducted or a visit that is conducted over telemedicine, and what is the reimbursement for that procedure, what is the co-payment, what is the co-insurance, how many remaining visits do you have for this type of procedure. All of that today, many times the provider has to pick up the phone and understand, or they're doing it on the back end when they bill it and seeing the difference in the reimbursement rates, or if it gets denied, they have to go back and do a lot of grievance and appeal, a lot of procedures on the back end of that claims processing revenue cycle to make amends for it. So by putting this up front in the eligibility transaction, the providers can cut back on all that administrative burden and get the information they need when they need it, even before they schedule the telemedicine visit. Another key component that was added in this set is the procedure codes. We've enhanced the requirements in the request so that providers can put in, for example, a CPT code or HCPC code for physical therapy, occupational therapy, surgery, and imaging, and get back a response from the health plan that's specific to those benefits. Again, really helpful for providers in scheduling the next future visit for occupational therapy and physical therapy, because they know exactly how many visits remain, knowing if there are differences between a surgery for a copayment or a deductible, knowing exactly what that might be, right? There might be benefits for certain types of procedures and a different set of benefits for other types of surgery procedures, and that can impact what that copay is. The third item that we've added is also additional service type codes, and these are the codes that are based within the eligibility transaction today, adding new mandatory STC codes and discretionary codes so that when the provider can drill down into specific benefits. And these are usually specialty benefits that are related to specialty topics. So if you are a specialty provider or support specialty providers, these additional STC codes can help you drill down into those specific benefits that a particular member may have in their benefit package, as they are variable on the back end of the health plan. These specific codes are can help aid, again, finding those exact dollar amounts and number of remaining visits for those specific explicit STC codes. On the next slide are the next three topics that we've also addressed in this update. The first one is the prior authorization and certification. This is a requirement to return, again, at the STC code or at the procedure code level if that particular STC code or procedure requires an authorization or a certification. And so the health plans can return this information so the providers know, oh, if I'm going to move forward with this particular procedure, I can also kick off the prior authorization now, instead of waiting till after the patient leaves and doing it on the back end and then calling the patient back later and confirming the date for the procedure. So a lot of that administrative burden can be removed by bringing, again, this type of confirmation to the front at the beginning of the service. Another item, I mentioned this before, is the remaining coverage benefits. Adding this particular type of data in the response transaction to the eligibility inquiry allows the provider to understand exactly how many remaining benefits are available for use for that particular member for these particular services. Again, this really helps providers manage the care when the patient's in the office for that initial visit. We've also included an update to our tiered benefits. It's really important for providers to understand the coverage details, patient financial responsibility, remaining benefit coverage, authorization status, in and out of network determination, if and how this particular provider is inquiring about a member, where they sit within that network. Because for some benefits, they might have, for certain procedures, they may have certain levels of reimbursement, and they might have a different contract with the health plan for these other types of members in these other networks. All of that can be helpful for the provider to understand earlier in the revenue cycle rather than later in the revenue cycle. I just want to note too that as part of our proposal for NCVHS, the eligibility and benefits single patient attribution data content rule was also moved forward for consideration by NCVHS to consider. Again, this is a patient attribution status that would be in part of the 271 eligibility response back, so the provider would know if this particular member is attributed to them in that type of contract. And that, so it allows the provider to understand exactly how this patient fits within their roster of patients, and so they know exactly how to bill and how to interface with that patient at the time of service. Again, at the beginning of the service when they're meeting with the patient for that first day. As you imagine, there's a number of benefits for operating rules considering these 6 updates to the eligibility and benefit rules. Erin, some ideas here?
Yeah, Bob, I think you mentioned a lot of the benefits in your presentation itself, but I want to highlight some of the potential costs and expenditure benefits and time savings that are associated with these rules as well. In the 2021 CAQH index, which included data from 2020, we saw that the cost to conduct a manual eligibility and benefit transaction increased almost double from what it was the previous year. And through our interviews and follow up with our stakeholders and data submitters, it really demonstrated that it was the emergence of telehealth during COVID-19 that drove this increase, as many eligibility verifications had to be done via phone, which is much more expensive and manual. So the telehealth requirement is really critical to driving that last 11% of manual and partially electronic eligibility transactions to become fully electronic. And when you think about $15 in savings per transaction, multiply that across the billions of eligibility transactions occurring in the industry, there's a real opportunity here. When you think about the attribution rule that Bob just described, this year's index, we also asked about attribution and put out an issue brief earlier this year. But what we found in that was that 62% of medical providers were spending more than an hour reviewing attribution information for a given value-based contract, and 45% of that group reported spending more than 3 hours, versus those that were receiving attribution information using the eligibility and benefits transaction. 75 of those were spending less than an hour exchanging attribution information for a given contract. So real benefits to including this information within existing workflows like eligibility. And finally, I think this goes to a lot of the comments Bob made. These are just immediate solutions to some business needs that have emerged since this operating rule was initially developed, including telehealth, increased usage of prior authorization. And also want to highlight that if new versions of the eligibility standard are introduced, always the operating rules are updated when a new version of the standard comes out to reflect the ongoing coordination, and any requirements in the operating rules that are in an updated mandated version of the standard are then removed. So that process is very iterative. Bob, I'll turn it back to you to talk about the new attachment rules.
Great, thanks, Erin. And as Erin mentioned, we do want to move into our last topic, and that is the new rules that we have drafted and written and published for the attachments. And what we mean by attachments really is any of that additional medical information or supplemental documentation that's used to support a clinical interaction that may have taken place with the administrative interaction that usually follows. As you can see from our index, about 20%, 21% of the attachments today are supported using a standard, whether that's the 275, NHL7 CDA. We've been able to track that through the index. Unfortunately, as you see on the right-hand side, many of the interactions that providers have to use when submitting an attachment is a manual process: mail, fax, email, uploading it to a web portal. Those types of interactions are highly manual today. So the core participants decided to write and draft operating rules to help support the infrastructure and some basic data content related to these transactions and interactions to help support the build out and allow the industry to move forward with a lack of a HIPAA mandated transaction or standard today. Because everyone is using something today to support these types of interactions. Health plans accept PDFs, they accept Word documents, they accept fax machine submissions, they accept the 275. Everyone does it a little bit differently, which again adds to the administrative burden for providers, because they often have to use a vendor or a clearinghouse or some sort of application or software, EHR even, has to support a variety of these methods, because every health plan does it just a little bit different. So how can we ensure that as the industry progresses towards a standard that, because they're using all the standards that are available today, how can we ensure that the industry can move forward together? And what we've done on the next slide, you'll see that we've drafted some pretty broad operating rules related to infrastructure. Again, as mentioned before, infrastructure talks about system availability, connectivity, processing modes for real-time or batch, acknowledgements, and companion guides. Because these are attachments, we've been able to add a couple other types of things in here for infrastructure. That includes file size requirements and electronic policy access. And what we mean by that is that if you are a health plan and you know that you need specific data that's not currently part of an 837 or a prior authorization form or a claim format or a claim form, you need that image for adjudicating the claim. You need that image for supporting a prior authorization request. Those types of policies need to be available to your providers electronically. So we've established a basic set of infrastructure requirements for both Next-12 methods, so if you're conducting the 275, for example, or if you have set up systems or applications that use a non-Next-12 method. There's basic requirements, again, those rules of the road and trading partner agreements to establish these basics so that you can build systems that connect. You can build applications that support these types of requirements. So these are kind of broad, right? But everyone can build towards them if you have it already, and you can build towards things that ensure connection, security, authentication, file size types of requirements, and everything can be published in a companion guide so everyone knows what to expect when they're trying to connect with you. So again, basic requirements for infrastructure. We've also developed some requirements for data content. And these are, again, high level, but based within the findings from our work with both our prior authorization and our claims work groups. You'll see some of those requirements on the next slide. We've defined certain requirements for a non-X12 method and certain requirements for the X12 method. Much of this relates to how a provider can connect a claim or a prior authorization request with the associated attachment that would come. That would follow that claim or follow that PA or be submitted at the same time. Unfortunately, or the way that the systems and applications are set up today, those are often, it's a bifurcated process. The claim goes in first, the provider gets append or denial that we need an attachment. The provider then has to upload or submit the attachment to remove that append or to work that denial. Same with prior authorization. Prior author goes in, provider doesn't know exactly what to send. They wait to get an update on the status. Oh, we need document XYZ from the medical record. Please send those in. The provider then identifies those and then sends those in, usually through different applications, different dates, different times, and through different vendors. So how can we tie these types of transactions that come in for the same purpose, care for a patient, but they come in through different systems, applications, and different time windows? That's through reassociation and through certain data, both on the claim and the PA, as well as on the attachment. So the core participants identified certain sets of data to help reassociate these documents with the claim or with the prior authorization to ensure that the health plan can reassociate them once they receive both of those, and then can more fully adjudicate the claim and the prior authorization with all of that needed data. So there's certain codes that can be turned on, there's certain items and certain data elements within the medical record, within the image that's coming in to help remove those pins and help support adjudication. So those types of requirements, again, are specific for a claim and for PA, but we have those available. As you can imagine, on the next slide, there are some benefits of adoption of these types of rules. As I mentioned, just providing some standard agnostic solutions to help relieve and reduce some of the burden for application vendors and providers and for health plans and building out the scope of attachments, right? The use case approach is really helpful. And I think that as you consider implementation of these types of infrastructure rules and basic data and transaction reassociation types of elements within your own system and application, having guidance, having those guide rails out really allows you to do that. Again, you can make meaningful investments in those systems and applications and technologies to help reduce the burdens of the collection and submission and processing and adjudication of claims and prior authorizations. All of this is really a way to help deliver better care for patients. Again, looking at the systems and applications today, where they're at and where the systems and applications need to be tomorrow, allowing, again, having those gateways up, having the basic requirements related to infrastructure really helps support that. So with that, I'll hand the call back over to Erin.
Thanks, Bob. Go back one slide. At the beginning of the call, we talked about the timeline with the attachment standard and the operating rules. And I do see a question coming around asking if we could talk about the 275 operating rule requirements regardless of the 278 being mandated or not. You know, the operating rule requirements can always be used whether or not there's a mandate if your organization is using the 278. The delay of an attachment standard does provide the opportunity, as we talked about, to align the adoption of operating rules and the standards to really allow for a single efficient implementation across the industry. The unified agenda does signal support for potentially multiple exchange standards for attachments, such as the 275, the X12, HL7 CCDA, HL7 Fire are all things that are being considered. And these operating rules support consistent infrastructure across all of those types of standards so that stakeholders can have similar expectations for security and authorization and infrastructure regardless of the standard being used, which I think will be really important as we are looking at really the first time we've potentially had multiple standards for a single transaction under HIPAA. When we think about the impact, we turn to the CAQH index and see that manual submission of attachments cost the medical industry more than $5 per transactions, and automation could save upwards of 75% per transaction. I think in the dental industry, this number is even higher because of the high volume of attachments used in the dental industry. So we are in the process of working with some partner organizations to measure the impact of the operating rules very specifically, in addition to what is already a pretty strong understanding across the industry on the value of automation and electronic attachments rather than manual. So we look forward to sharing those results very soon as well. Moving on to the next section, I'm gonna share a couple bits of feedback and resources regarding the NCVHS comment periods. I'm sure you are all working very hard on your comment letters. It was a quick turnaround time. They are due a week from today. You can send your comment letters to the NCVHS email address here. There's a link to the request for comment, and they have asked for a specific subject line. Again, you can respond just about the operating rules or also the X12 proposal as well. So on the next slide, for those of you who are really crunching, we have created a dedicated website to support stakeholders that are evaluating and commenting on the proposed operating rules. So at this point, there is a lot of material on there, including links to all of the proposed rules and the board's recommendation letter. We have created cheat sheets to show the difference in requirements between the current mandated operating rules and the updates that are being proposed. There is a guidance document to help you understand what NCVHS may be asking about in their various questions. There's a pre-recorded webinar, although very similar to the one Bob and I gave today, as well as a toolkit to help you think about how to measure the costs and benefits of implementation at your organization, which we've based off of some of the work we do through the core certification program to help organizations quantify the cost and benefits of implementation. So I'll now turn it over to Tim Kaya, who has graciously joined us today. Tim, as Jackie mentioned earlier, is the immediate past chair of the core board and oversaw a lot of the updates and new attachment rule development during his tenure as board chair. Tim's going to talk quickly about kind of some last thoughts on the benefits of the rules, and then we're going to do a little Q&A. So please feel free to add your questions into the question panels as well for Tim or Bob or I.
Yep, sounds good. Erin, can you hear me okay?
I can hear you great, Tim.
Okay, excellent, thank you. So in this last slide in the deck, I thought appropriate for us to wrap up with a summary of how the proposed new and updated operating rules will facilitate the evolution in healthcare data exchange that we're actually seeing now across the industry, and will get more intensive as time goes on as we get deeper and deeper into value-based care. The future, though, of operating rules really requires the flexibility to support, and I think you heard this today, both EDI standards, which happen millions of times today, and API standards as they evolve and become more prevalent in all of our businesses. So the proposed operating rules really support legacy transactions that are deeply embedded into our administrative systems all the way back from the time when 4010 was created and even before that, but also provide a bridge to support emerging standards for transactions like attachments that you just heard about, through requirements that align to multiple standards and ways to get information across. The specific set of proposed rules better reflects the 24/7 nature of our business, our healthcare business, by aligning modern security requirements, the growing complexity of benefit design, and the need for more granular coverage information at the point of care. So specifically, three things. One, the updated infrastructure and connectivity rules, as you guys just spent some time on, increase security and system availability, meeting today's needs for information exchange that happens really round the clock in healthcare today. The second one being updated eligibility and benefit rules, and it was the right time to do this, particularly addressing telemedicine, the complications associated with prior authorization and documentation required around prior authorization, different benefit designs around prior authorization, and they dictate the provision of more granular data about enrollee benefits and involvement with value-based payment models. Access to this information real time and at the point of care will drive automation, downstream efficiencies, take a lot of phone calls out of our system that don't necessarily need to be there. And then lastly, the brand new attachment rules, which even though we don't have a fully functional 275 yet per se, provide a standards agnostic solution for complicated and wasteful attachments that don't necessarily provide for reassociation in support of both prior authorization and healthcare claims adjudication, which is so needed today. They support a wide range of standards under consideration by HHS, as you just heard about. Probably one of the most compelling things around this is the organizations that are actually part of CORE today and the percentage of American lives that they represent across their businesses. So the CORE participating organizations today represent about 75% of covered American lives between private and government payers. And what was interesting about all these things that you just heard about is, on average, 90% of the CORE participating organizations were in full support of all the operating rules that were shared here. And this is by far and wide the largest margin of support that we've had across the industry on operating rules. So I think those are some of the main points in summarizing all of this together. And I'm gonna, Aaron, I'll turn it back over to you because I know we want a couple of minutes here for Q&A.
Yeah, Tim, thanks so much for that. I have a couple questions for you that have come in through the chat and through the registration. But in general, the CORE board is responsible for identifying and approving which operating rules are proposed to NCVHS for federal adoption. So I'd love to hear in your words why the CORE board unanimously supported this particular set of new and updated rules for federal mandate.
Yeah, good question. I think the discussion that you and Bob just had with the group on the phone here, outlining the benefits and kind of the summary slide that we just presented is one piece of the puzzle. However, the board proposed this operating rule for recommendation by NCVHS to HHS really for three primary reasons for national adoption. One, the updates to existing federally mandated rules respond to the immediate industry need to align requirements with current and emerging business operational security and a bunch of other things that are necessary to promote technological advances within the industry. Some of the rules that we had before were created 10 years ago. They don't necessarily represent modern ways of how the industry is behaving today and interacting today in its exchange of both clinical and administrative data. So for example, updates to the CAQH core eligibility and benefit data content operating rule addresses gaps in the mandated version to support crucial business decisions really arising from changing care settings namely in telehealth and the different benefit designs that are out there around what copays go with what care settings, and the influence of regulatory priorities that have evolved over the past 10 years. So that's really, number one. Number two, consistent with the NCVHS recommendation in 2020 for CAQH Core to develop an updated connectivity rule, the version 4 connectivity rule that you heard about today supports uniform interoperability requirements across both clinical and administrative transactions and in between, building on the industry's interest to establish predictable, consistent connectivity methods that enable a standards agnostic approach to exchanging information across our industry. And then the third one is really the operating rules lay the foundation for an industry in transition. If we were here 5 years from now, the amount of business that's transacted outside of EDI because of the real-time nature of what's needed there will explode. And we need to create common expectations to enhance the exchange of attachments, in this case attachments, to drive electronic adoption, regardless of the mandated standard. So you'll see a whole bunch of different ways to move information back and forth in attachments and reassociating that information back into the claim and into the prior auth. So those three things, I think, really drove the kind of the overwhelming, one, the need, and then two, the energy for folks to get together and put the operating rules together as you just heard them today. And then, of course, adoption across the group that across all across the CAQH core. I don't know if that answers your question or not, Erin. It was probably a long-winded answer.
Yeah, no, that's really helpful, Tim. And you've mentioned several times now some of the broader healthcare interoperability efforts going on. We saw the prior authorization proposed rule come out this week. How will these operating rules support broader healthcare interoperability efforts?
Yeah, again, it goes back to this industry in transition. And what's exciting about this is the set of rules, they don't take your foot off the gas on existing rules that are out there and standards that are out there, but they allow us to actually come together on emerging business needs and the standards associated with those business needs around interoperability. The updated connectivity rule, as we talked about, establishes consistent connectivity requirements for data exchange across all mandated transactions addressed by CAQH core operating rules, and can be used to support other standards as well. The standards agnostic approach, if you think about OAuth 2.0, SOAP, REST, and other API technologies, gives flexibility to the industry in how to communicate. And then the single uniform connectivity rule, like the federally mandated phase 2 CAQH core connectivity rule, is a safe harbor connectivity method supporting the needed intersection between clinical and administrative rules. Further, the proposed rules facilitate, I'd say, the use of existing standards like X12 in harmony, and this is a theme you kind of hear again and again, in harmony with new exchange methods like HL7 FHIR and providing a flexible framework, which would provide a flexible framework for the future. So those are a couple of examples around how operating rules will support broader healthcare interoperability efforts.
Thanks, Tim. One of the topics that NCVHS asks about in their request for comment is implementation costs and perceived benefits of the operating rules. What benefits and ROI do you expect the proposed operating rules package to have for healthcare plans such as United Health Group?
Yeah, and I'll really speak to like everyone, not just specifically to United Health Group, but to the industry as a whole. Back when 5010 came out a number of years ago now, and the operating rules that were associated with it I mean, there were similar hearings around NCVHS around the operating rules, but at the time, if you really dug into it, started to realize that the operating rules create structure around things that might be a little bit loose, that could be tightened up, and indeed probably were tightened up in subsequent versions. But they take a lot of variation. They take variation out of the equation. And as you all know, variation is the enemy of being able to have the right level of cost control out there. So, you know, back when 5010 came out and the operating rules, the first set of operating rules around claims and eligibility, they created structure, needed structure, so that payers and providers alike could figure out, you know, where certain fields needed to be, when can I submit this stuff, and what are systems going to look like to be able to accept it. And it's really that combined with the rule itself that created tremendous value. I'd expect health plans, though, will experience a number of benefits on implementation of these proposed rules. You know, we're preparing, I would say most people are probably preparing, or most organizations are preparing around the implementation of attachments. It just makes sense, and it makes sense to be able to reassociate attachments with claims and with prior authorizations. And you would do that, I would think you would do that if you looked at business cases around it and satisfaction of provider payer satisfaction out there, regardless of what the NCVHS's recommendation might be. You know, and while implementation of any new or updated operating rule requires upfront investments, the time and cost savings associated with the rules are really well worth the investment over time. And we'll get to see that and how those things kind of come through in the use of transactions, particularly the EDI side of this, as the CAQH index report gets published in January. But, you know, some examples here: updated system availability requirements will aid all stakeholders in maintaining reliable automated exchanges that are available on a consistent schedule. It also gives some health plans the flexibility for more downtime per quarter, but calculated downtime per quarter to support system upgrades and migrations. Secondly, updated eligibility and benefit rules. I mean, this was, as I mentioned before, I think heavily needed in order to reduce volumes of calls related to eligibility verification and drive more automation. I think Bob might have mentioned this in his discussion around every phone call costs $15 per transaction. And as we venture deeper and deeper into value-based care, I would expect to see more granularity associated with the types of benefits that are out there, particularly where care is delivered, how care is delivered, et cetera. And then, you know, lastly, as we've talked about on the attachments rule, some of the minimum file size requirements will take some of the questions out regarding exchange of information, or the burden of exchange, and you know, all of these requirements that we just talked about will reduce time spent reviewing documentation that's today submitted and reviewed manually. You know, I would say value obviously is there on the, you know, in the cost takeout basis and an administratively burdened system that we're in today, but there's also this growing need for satisfaction across providers in our industry, that the administrative burden that this industry has placed on providers, there's no question it could get worse in the future in value-based, or it could get a lot better. And the operating rules that we're putting in place here and the flexibility around those operating rules should help it get a lot better, to create a spark, if you will, back in the practice of medicine.
Great, thanks, Tim. I know we're coming up on the hour, so Jackie, I will turn it back to you to close us out. And Tim, thanks so much for spending time with us today and sharing your thoughts with the group.
Thank you.
Thanks, Erin. Before we sign off, I just wanted to quickly let everyone know that we do have one more webinar scheduled for the rest of this year. It's next Friday, December 16th. And it's going to be a quick half-hour webinar talking about CAQH core recertification. So if you are from a core certified organization and you're interested in learning more about the recertification process, please join us next Friday. And otherwise, I just want to thank you all for joining us today and hope you have a great rest of your afternoon. Thanks, everyone.
Bye.